Thank you, Rashmi. It's really, my first slide is on purpose. It's really a privilege to be part of this community for so long. I think Rashmi is really sort of extraordinary at bringing people together, not just to have them together, but in pursuit of a goal. And I think, there's been a lot of progress, certainly not as fast as we would like, but I think that's always the case. But really a dramatic improvement in the trajectory of our field, and I think a lot of that has to do with this foundation. So it's a privilege to work with you all. A few disclosures, certainly nothing that's been lucrative. So I thought I'd start with just, some questions I have to ask myself, which is, what the heck is systemic JIA? Is it a 2-year-old who's had a prolonged fever and kind of miserable, and the fever becomes kind of an every afternoon thing? There's not really any infectious symptoms. Maybe a little bit of this rash that breaks out with fever, but later on in the course, gets called Kawasaki disease and gets treated for that, but doesn't really have much of a response. All the infectious and other tests have been negative. The labs show lots of inflammation. Some rheumatologist strolls in and says, oh, the knee is swollen, and nobody really knew about that. And is that Still's disease? Is that systemic JIA? Or is it a 10-year-old who initially has some fever and then some joint pain and stiffness that kind of gets more and more painful over time? The fever sort of abates, never really had any rash, and now is just left with really kind of crippling arthritis in lots of joints, especially in the hips. And here's an MRI that really has sort of all the bad things happening. There's inflammatory arthritis, there's degenerative or osteoarthritis, there's even a little avascular necrosis of these hips. And this poor 10-year-old is going to need to have these hips replaced, and they're just biding their time until they're done growing so that they can get a bilateral hip replacement. So is that systemic JA? That seems like a very different scenario than we just talked about. Or what about, this little 18-month-old? These are all real patients I've helped care for, who has trisomy 21, and was well until 18 months, started developing this prolonged fever, had a big liver and spleen, had some low cell counts with anemia and platelets and liver irritation, and then low blood pressures, and things are really starting to get serious. Big workup looking for infections and cancers, and really nothing happening, and unfortunately gets moved to the intensive care unit because the blood pressures are so low. And so my answer is yes, all of these are sort of underneath this umbrella of systemic JIA Still's disease, which really creates a challenge, I think, for trying to put our finger on what we're actually talking about. And then when did this syndrome sort of become systemic JIA? The same patient who outside of this acute presentation is always just, kind of teetering on the edge of a flare. And then someone just on a routine check notices that the fingers look kind of puffy, and sometimes erythematous, which leads them to get a chest CT, which has this really funny pattern that looks a little bit like an aspiration pneumonia sometimes. And then, maybe they move forward with a biopsy, and it has a pretty unexpected finding of pulmonary alveolar proteinosis. Not something that was originally described for systemic JIA, but has certainly become a problem, certainly too familiar for some of the people on this call. So this is George Still. He was around, a long, long time ago. And he actually did not name the disease Still's disease. He just described this syndrome of childhood arthritis with fever. And it was some of his proteges in the decades later that called it Still's disease. There are a number of other things that are called Still's. There's a Still's murmur, which is a sort of benign heart murmur, totally unrelated. And he also described ADHD, near and dear to my heart. So the history of what was once Still's disease is that in the 60s, it got lumped in with juvenile rheumatoid arthritis. And it had, it was basically fever and chronic arthritis, and it had a bunch of criteria. And over the years, those criteria have sort of evolved from JRA to JCA to now JIA. And these criteria developed in 2001. And we're not going to go through these extensively, except to say, this is what the textbooks are saying we should be calling systemic JIA. It starts with arthritis. You have to have arthritis in a couple joints for at least 2 weeks, and you have to have a fever most days it usually follows a quotidian pattern, which is that like once a day, usually afternoon. And then you have to have some other stuff. It can be a rash. Which one is the Stills rash? You've already seen some pictures of Stills rashes. Are they all? Are they none? Where will the salmon land? So according to Google image search, this is the Stills rash, not these other ones. These other ones are the rashes of some autoinflammatory syndromes, some infections, Kawasaki disease. And my point here is just to say, you know, the Stills rash can look like lots of different things, and there's not like a classical Stills rash, but often there is a rash more prominent with fever. Adenopathy, this is just big lymph nodes, and anywhere you can have lymph nodes, they can be big, and that kind of counts. Usually we're looking in the neck, but they can be in the axilla or the groin, or they can even be inside the chest or inside the abdomen where we can't find them on exam. You can have a big liver or big spleen, sometimes pretty hard to detect, especially if you're not going to do any kind of specialized imaging, or if you have a kid who is squeamish or ticklish. And then this thing called serositis, which really is just inflammation of the lining of some of the organs inside our chest and abdomen. So you can have pericarditis around the heart, you can have pleuritis around the lungs, you can have peritonitis around the abdomen. But probably the most important criterion is that it's not something else. And this is the sort of long list of, and certainly not exhaustive, of the something else's that have to be considered anytime that you're thinking about making a diagnosis of systemic JIA/Still's disease. And so, you know, obviously I'm bouncing back and forth between the names. And so why should we decide to call it systemic JIA versus Still's disease? Well, you know, it's systemic, it's arthritis. What's the problem? And changing names is hard. We already have all of these papers and infrastructure and amazing foundations that are named systemic JIA. And then if it's called JIA, we can kind of work together with the other JIAs for advocacy and fundraising. And so there's benefits to being in the JIA field. But there's also some costs. Biologically, it seems just completely separate from all the other kinds of JIA. Genetically, the biomarkers are different. The responses to treatment are different. The adults have been getting along just fine calling it Still's disease since originally described in children. They call it adult onset Still's disease when there's no pediatric Still's disease. And thanks to work from people like Bas Foster, who runs a really nice registry in Europe, we can kind of say that whether or not you have arthritis as part of your disease, it doesn't really make any difference. It's all still one thing. And so, you know, Dr. Fotrell is going to talk later, very recently helped lead an effort where he said, why don't we just call it Still's again? And this is a picture of Dr. Fabrizio De Benedetti, who's also a European pediatric rheumatologist. We're stubborn. Okay, fine, we'll call it Still's. And so the Europeans have decided to band together and say, we're going to call this Still's disease as one collective entity. And I agree with that. Hopefully that will stick moving forward. And so what is this thing, macrophage activation syndrome? Is that the same thing or is that totally separate? So this is the syndrome of macrophage activation syndrome. It's fever, it's some low cell counts, abnormal clotting where they have little microclots everywhere, or DIC, liver involvement, these funny activated macrophages that have eaten other cells, especially red blood cells called hemophagocytes. And of course, this really high blood biomarker called ferritin, with the potential that this progresses into something that looks like shock and potentially organ failures. And here's some of the organs that like to be involved: the liver, the spleen, and unfortunately the brain. So what isn't macrophage activation syndrome? It's not really a cause. It's really kind of a description of the kind of inflammation that someone has at a given point in time. And, you know, I don't really think of MAS, especially for a lot of our patients, as kind of this light switch where you have it or you don't, but really more of a spectrum where, you know, you have, especially the more systemic of our Still's patients, have a lot of these symptoms. And when they become more severe, they hit some semi-arbitrary threshold where we start to call it macrophage activation syndrome, especially when there's some of these dropping cell counts or coagulopathy. So I think of these things in the more systemic flavor of systemic JA as a spectrum. Okay, so my task here is really to tell you what causes systemic JIA. There's a lot of hypotheses floating around. You've heard the term autoinflammation. We've talked about IL-18, abnormal viral responses. Everything's a virus in pediatrics until it isn't. And then maybe you've heard about this thing called HLH, or a genetic problem with your killer cells. And the answer is, honestly, we don't know. It remains a big enigma. And in part, it's because we're probably studying more than one way of getting to the same sort of phenotype. And so, I think every kitchen has a bit of a junk drawer. And I think Still's disease, SJIA, is a bit of a junk drawer where they're all in the same place and there's a fairly similar syndrome, but how you get there and what it actually is it can be lots of different things. It can be a prolonged viral response, or it can be regular old JIA, but had a febrile presentation. We talked about Kawasaki's or autoinflammation. So when we say Still's, I think we're still kind of not talking about one very specific thing, but more sort of a group or a family of presentations. So we keep coming back to this term autoinflammation, and what do we mean by that? I won't make my joke about cars on fire, but autoinflammation is persistent inflammation that is not explained by infection or cancer or antibodies or antigen-specific T cells. And so I have drawn up sort of this 6-part overlapping wheel of immune dysregulation where you have different categories. And you might be familiar with things like autoimmunity, where your immune system is too much, is behaving badly, and it's responding to a self-antigen, something that's part of you, as opposed to like allergy or atopy, where it's a harmless antigen that you're responding to. Autoinflammation is there's just too much inflammation, but there's not one specific thing, whether it's a virus or a pathogen or a self or a pollen molecule. It's just kind of the alarm for our innate immune system kind of going off inappropriately, and that's kind of what we mean by autoinflammation. So I thought we would talk about the pathology of Still's using the characters created by Rashmi in 3 acts. And so we have to introduce the cast first. This is Poly, which is short for polymorphonuclear cell because they have funny nuclei, or we usually call them just neutrophils. And they react really quickly, and they're pretty destructive and not very precise. And then there's Gronk, the natural killer. He's also very fast, responds very quickly to things, a little bit more tactical. He's a bit more of a killer than just sort of spraying destruction everywhere. Then there's Terry, the T cell. Terry is a little slow to respond, likes to see what's going on first, very strategic. And when Terry gets going, very potent and very bossy, likes to tell other characters what to do. And then finally, of course, there's Mac. He's a macrophage. He's always around, and he's very suggestible. Whatever someone sort of tells the Mac to do, it's going to do, and it's going to do it with gusto. And then we'll talk more about these little wee beasties later. So first we have to set the stage. Our cast of characters is home at homeostasis, and they're just living equitably and not causing any problems. And then there's some sort of trigger, and this is where I can't tell you what the trigger is. It certainly could be a viral infection, but it's not always, or not clearly. And so that's our little lightning bolt. And then our neutrophil Poly, he's the fast one. He responds really quickly. Hey, I'm going to go check that out. I'm going to go see what's going on. And Poly likes to make these cytokines, IL-1 and a little less IL-6, but makes these sort of cytokines that you might be used to if you're dealing with systemic Still's disease. Gronk, our NK cell, really hasn't helped anything. Our T cell's really not very interested. And because Mac is so suggestible, he's going to go help. And their response might just be this sort of typical initial presentation: fever, swollen lymph nodes, maybe some rash. And then, in the typical course of Still's disease, about a third to a half at least of patients who have a diagnosis of Still's disease have what we call a monophasic course, which means things can be pretty inflammatory, but often we just have to sort of give some steroids or block some of these things, and the patients have a kind of monophasic course. And then, Poly and Mac leave, and the T cell and the NK cell never really got that excited. And so that's the sort of hopeful outcome, but it isn't always what happens. Sometimes there's over triggering. And so it starts in roughly the same way, where you have, your neutrophils and your macrophages responding quickly, and they're causing fever, adenopathy, and rash, maybe a little arthritis in this scenario. But our T cell is kind of paying attention and wants to know, when they're going to be back. And so, if they stick around for a while, especially if they've sort of set up shop inside an arthritic joint, they're going to keep sort of pumping out these cytokines, IL-1, IL-6, and lots of other stuff, and causing some damage. And the T cells decide they better check in on that. And so the T cell says, yeah, there's all this IL-1 and IL-6. They must be detecting something horrible going on. The neutrophils and the macrophages are, I don't know, maybe listening to themselves. They make these cytokines and they can respond to them. And it just kind of persists. And we postulate that this other cytokine, IL-17, that can come from T cells helps perpetuate this process. And that maybe becomes this scenario of the patient who the fever becomes less of a problem and the disease really becomes socked into their joints and really, really hard to take care of. And that's where the T cells become kind of naughty, as they help lock these things in and make them very hard to treat. On the other hand, you can have a massively triggered response. And again, I can't tell you what the trigger is, but in this case, it really seems to drive Mac, who was sitting there unassuming, to just pump out all of this IL-18. And IL-18 can be, really sort of a misbehaving, like an IL-8 teenager. The neutrophils do what they normally do, go and sort of check things out. But Mac has really just been possessed, is pumping out all this IL-18. And, T cells really notice IL-18, respond to it in a very inflammatory way. And so you start with this fever, adenopathy, and rash. But things can escalate quickly with all this IL-18 around. The T cells have really gone nuts. So much IL-18, something must be very wrong. They have to fix it. And the way that this T cell is going to respond to IL-18 is by making tons and tons of this caustic cytokine called interferon gamma. MAC is still just pumping out IL-18 at levels that we see in really no other disease. The neutrophils and the NK cells have kind of left the party. They somewhat respond to the interferon gamma. They might try and turn off this whole process by making something called IL-18 binding protein. So they're trying to bind up some of this IL-18, but it's just not enough. There's too much of it around. And the product of this interferon gamma is that it jazzes up all the other macrophages and other immune cells. It really amplifies and potentiates the effects of the other things that were already around, like IL-1 and IL-6. It makes other macrophages hungry for blood. And here's the little red blood cells that get gobbled up to form hemophagocytes. And that's sort of this trajectory into macrophage activation syndrome, which seems really closely tied to all of this IL-18. And so some of the sort of practical application of that is we can use IL-18 as a pretty good diagnostic biomarker. So this is just a bunch of different things we can measure in the blood, comparing different inflammatory diseases like systemic JIA, other JIAs, Kawasaki disease, systemic infections, and leukemia. And you can add lots of other things to this, but it really is sort of a binary difference where the IL-18 levels in many Still's patients are pretty diagnostic. And increasingly, that's becoming part of the way that we make this diagnosis. So do we have two different subtypes? Yeah, it seems like IL-18 defines the more MAS-like and IL-6 the more arthritic-like. And that maybe, IL-18 bridges autoinflammation with this HLH-MAS-like hyperinflammation, whereas the arthritis kind is really more between autoinflammation and autoimmunity. So to wrap things up, Still's still widely variable, certainly potentially deadly systemic inflammatory disorder. We still don't really understand the origins of this disease. It has some of this autoinflammatory flavor, but in many patients, it can have an autoimmune flavor. And we're really centered on these cytokines that we've discussed, like IL-1 and IL-6, and this, especially in the MAS-prone patients, this IL-18, which seems to be pretty good at driving interferon gamma. So I'll thank in advance Dr. Fotrell, who's going to do a much more adept clinical summary. I'll end with saying the future looks actually pretty bright for Still's and systemic J. We have a lot of new treatments. We have a lot of good research ideas. We need to figure out some new things, like how do we predict what trajectory somebody's going to take? What's going on with all this IL-18? What's the nature of the triggers that sort of flare our diseases? Um, which treatments and when to stop them, and then really importantly, how do we prevent some of these chronic complications, definitely including lung disease? So the future looks bright, but there's certainly a lot of work to do. I'm really grateful to work in a really great community, a multidisciplinary group at Children's Hospital in Philadelphia that we call our dysregulated immunity response team, or more legitimately, our immune dysregulation program. And moreover, really happy to be part of this amazing community. Thanks.
Framing the first question is that how can you lower the CRP level for a 18-month-old baby? Can any food or diet help? And this is a question that we often hear.
Yeah, we often get it as well. I think that everybody is on this quest for the anti-inflammatory diet, and certainly a lot of work has been done looking for it, and really there's not much to be found. Now, certainly if there are children that have, bad food allergies, that can be a contributor to inflammation in any context. I can say that every time we look for those, it never seems to be something that makes a big difference. In general, the anti-inflammatory diet is a healthy diet, which is like lower in processed foods and salts and that kind of stuff. So, and simple sugars. So, if you're eating what is considered to be a healthy diet, that is sort of anti-inflammatory, but specific foods, whether it's turmeric or sour cherry or who knows what, really, we don't have a great sense for those making much of a contribution.
Got it. So another question which will about IL-18. Any explanation for the high IL-18 without symptoms, not technically diagnosed with SJIA stills?
Yes, from a audience member with a lot of experience with this exact question. So I think that IL-18 doesn't do a whole lot by itself. It really is there to kind of amplify other things that are going on. So it is certainly possible for people to walk around with really high levels of IL-18, often for decades or years. And we think that those folks can have normal, healthy lives, have kids, have jobs. They're probably at risk for, in certain triggering situations, having a much bigger response. But it may also be that certain people are better able to sort of compensate and regulate that than others. We're still trying to understand exactly how that goes. And there's some genetic diseases where the 18 is never going to come down. In most stills patients, if and when they can kind of get things under control, it can be normal. So we do use it as a sort of minimal residual disease activity marker outside of those rare genetic diseases.
We'll do one more question. Have any answers? How often do patients present with peritonitis instead of heart or lung lining inflammation?
That's a great question, Kristen. I don't have hard numbers for you. Not super often. I'll say, I can't say that there's not a little sort of subclinical. When we do see this serositis, we usually see pericarditis. We can see peritonitis in other autoinflammatory diseases, especially like FMF, but it's not a super common part of the presentation.
Yes. Okay, let me see the time. Actually, we can do one more question. What was the next one? Are there genetic tests you would recommend? I know Scott will like this question.
You know, it is an open question. I would love to be in a place where we were all kind of just getting genetically tested and comfortable with not having a result that is clinically useful. So, I'm always in favor of early genetic testing, but I think I have to be honest and say that in most stills patients, genetic testing hasn't really changed their clinical, picture outcome. Certainly, if things present really young, we usually pursue genetic testing pretty early. If things have been sort of really troublesome or refractory, we'll pursue it. And that's not to say that we have not found genetic diseases that probably were called stills in the past, and that includes XIEP deficiency, NLRC4 gain of function, and there's a host of others increasingly. Um, so I think that it's a moving target. We're always learning more, but I think in terms of like the day-to-day management of any particular patient, it's not super common that it moves the needle. We still pursue it reasonably frequently. I just I don't want to build up false hope that like there's a genetic cause and that's going to really alter the trajectory. That hasn't been the case, even in a lot of the refractory patients.
So thank you so much, Dr. Canna. With that,
Thank you.